Hello and welcome to today's webinar, Diagnosing Psoriatic Arthritis, Challenges and Considerations. My name is Bev Bromfield and I'll be your moderator for today's presentation. Before we start, I'd like to go over a few items so you know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You've joined this presentation using your computer speaker system by default. This means if you hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, select Use Telephone in the audio pane and the dial-in information will be displayed. You'll have the opportunity to submit questions to today's presenter by typing into the questions panel on the questions pane on the control panel. You can send your questions in at any time during the presentation. We'll collect these and address as many as possible during the Q&A session with today's speaker, rheumatologist Dr. Elaine Husni. Before I provide information about the foundation, I'd like to acknowledge and thank our sponsors, AbbVie, Amgen, Bristol Myers Squibb, Janssen Pharmaceutical Companies of Johnson & Johnson, and Novartis for their support of today's webinar, which is an activity of Psoriatic Arthritis Action Month. Since some of you may be new to the foundation, here's a little background about who we are, our mission, and what we do. For over 50 years, the National Psoriasis Foundation has served more than 8 million individuals in the U.S. living with psoriasis and psoriatic arthritis. Founded from a tiny classified newspaper ad in Portland, Oregon, the NPF mission is to drive efforts to cure psoriatic disease and improve the lives of those affected. After completing one of the most ambitious strategic plans in its history, National Psoriasis Foundation launched a new 5-year strategic plan in July 2019. With a continued focus on a life free of psoriatic disease and its burdens, NPF remains committed to finding a cure for psoriasis and psoriatic arthritis while supporting individuals to live longer and healthier lives. Over the next 5 years, NPF will focus on achieving 3 goals: to lead collaborative transformational research in psoriatic disease, increase the lifespan and health of individuals living with psoriatic disease, secure the human, technological, and financial resources necessary to achieve NPF's mission-related goals. By attending today's program, you've already taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis, moving towards a better understanding of what it means to live with psoriatic disease. A few of the many ways that NPF supports the goal of leading collaborative transformational research includes, to date, NPF has funded over $24 million in grants and fellowships. This includes over $3 million in grant and fellowship funding last summer. NPF grant mechanisms support all stages of research and careers. Our efforts focus on areas of unmet need and are often conducted in partnership with research stakeholders with whom we collaborate. In addition to funding outside grants and fellowships, the NPF also leads research initiatives such as the Psoriasis Prevention Initiative and the Psoriatic Arthritis Diagnostic Test Grant, which are new to the foundation. The Psoriasis Prevention Initiative was developed at the recommendation of the Psoriasis Prevention Initiative Steering Committee, who urged the definition of prevention to better guide the proposal development. And that's how it expanded to disease, relapse, and comorbidities. NPF plans to invest $6.5 million over 5 years in this effort. The second initiative is the Psoriatic Arthritis Diagnostic Test Grant, which aims to develop a diagnostic test for psoriatic arthritis. This could significantly reduce the time between onset of symptoms and a diagnosis. This is important because we know as little as 6 months of delay between onset of symptoms of PSA and treatment and start of treatment can lead to permanent joint damage. You'll hear more about that later today. This slide highlights 4 NPF research efforts that you can be part of. Launched in 2015, the NPF Corona National Psoriasis Patient Registry is the largest independent observational registry of psoriasis patients in the U.S. The registry collects and studies patient health information, allowing researchers to compare the safety and effectiveness of psoriasis treatments, better understand conditions that are related to psoriasis, and explore the history of the disease. There are currently almost 12,000 patients enrolled at more than 270 sites across the country. Your dermatologist may be enrolled as an NPF Corona National Psoriasis Patient Registry site. Not sure if they are, ask. If they're not, then encourage them to join. The LIGHT study is a real-world research study that compares the effectiveness of home versus office-based UVB phototherapy treatment of psoriasis. Entry criteria for this study is simple. You must be 12 or older, have plaque or guttate psoriasis, and be a candidate for office or home phototherapy. There's no washout of topical, oral, or biologic medications, and the study is designed to be easily incorporated into routine patient care. It is also unique because it includes equal representation of all skin phototypes. Citizen Scientist is a platform where you as a patient answer survey questions, which you and researchers can analyze for trends and new insights. Citizen Scientist is currently being revitalized for greater community benefit. The NPF Annual Survey is a data collection effort the Foundation has conducted for 2 decades. This important research conducted each fall provides insight into the lived experience of individuals with psoriasis, including quality of life and unmet needs. If you're contacted about this annual survey, we would appreciate you sharing your experiences with us. To achieve the Foundation's goals as mentioned, please support our mission through donations or by participating in virtual Team NPF events, such as Stamp Out Psoriasis, Walk, or Cycle events. You can learn more at psoriasis.org/donate or teamnpf.org. On behalf of the National Psoriasis Foundation, thank you for attending today's webinar, where you'll learn more about signs and symptoms of psoriatic arthritis in comparison to other forms of arthritis or other diseases, why diagnosis of psoriatic arthritis is multifactorial and includes many factors to consider when screening for the disease, the important role of comprehensive care in the management of psoriatic arthritis, resources to continue to learn more about how to cope with a diagnosis of psoriatic arthritis. Now I'd like to introduce you to our speaker, rheumatologist Dr. Elaine Husni. Dr. Husni is the Vice Chair of Rheumatology and Director of the Arthritis and Musculoskeletal Treatment Center at the Cleveland Clinic in Ohio, where she is also the Director of the Musculoskeletal Outcomes Research and the Director of the Fellows Research Committee for the Rheumatology Department. Dr. Husni is actively involved in a number of rheumatology clinical trials at the Cleveland Clinic. Her research interests include examining health outcomes of patients with rheumatoid arthritis, psoriatic arthritis, ankylosing spondylosis, and osteoarthritis, specifically in the area of cardiovascular disease. Dr. Husni is also an assistant professor at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. Dr. Husni is a member of the National Psoriasis Foundation's Board of Directors, a past member of the Medical Board, and a professional member of the National Psoriasis Foundation. It's my honor to welcome Dr. Husni.
Thank you, Bev. Welcome, everyone. I'm really happy to be here. It is 7 o'clock my time on East Coast, and I do really want to thank you for joining in. I know that in our sort of pandemic or maybe post-pandemic phase, if I'm allowed to say that, you have lots of choices and lots of places to get your information. So I really do want to thank those that joined us through the National Psoriasis Foundation for tonight's webinar. This is really for you guys, for the audience who in some way either know somebody with psoriatic arthritis or psoriasis, or dealing with some symptoms, have been diagnosed for a long time, or just newly diagnosed. So this is really your time that I want to be able to spend some really focused energy around psoriatic arthritis and diagnosing. As you know, it's probably going to be really hard for, someone like me, even though I'm so passionate about psoriatic arthritis, to be giving you everything I know about this disease in the next half hour or so. But please write down your questions. Please, really try to think about things that may help other people in the audience who have been, dealing with this. And I'm really here for you guys to try to get as much information and understanding and possible for this disease. So what do we know? So we know that psoriatic arthritis is chronic inflammatory disease of the joints as well as tendons and ligaments. So what does chronic mean? So as you know, the word means for a long time, and we do consider this a lifelong disease. We don't consider it, you know, a necessarily you're put in jail or this is a death sentence. But from what we know, there's currently no cure. So we do like to be really realistic and upfront that, you know, everything that we do really slows down the signs and symptoms, but not cures. And it is an inflammatory disease as well. So about 30% of patients, you know, in this range, you know, depending on which study you use, it does range a bit. But having psoriasis is one of the biggest risk factors. And, you know, out of 10 patients that come into my office with, you know, let's say psoriasis only, about, you know, 30% or 3 or 4 out of those 10 may develop joint symptoms in their lifetime and then eventually be diagnosed with psoriatic arthritis. It can affect children as well as adults. It usually occurs between ages of 30 and 50. What's so interesting is that psoriatic arthritis actually is equal in terms of male and female. And so that's really different for us because as a rheumatologist, when I take care of patients with rheumatoid arthritis and lupus, it's actually very female predominant. So this is one of the only diseases that, you know, it affects males equally to females. It usually starts, psoriatic arthritis usually starts after psoriasis. So most of my patients will have 5 to 10 years of dealing with the skin disease before they even start developing some of the joints symptoms. Now, some people, it can happen together. And then in really rare cases, the psoriatic arthritis part can happen before the psoriasis becomes evident, but that's a little more rare. Most people have the psoriasis first, and then about 5 to 10 years later, will develop symptoms that we can attribute to psoriatic arthritis. I had mentioned that there's no cure, but treatments are really outstanding now, and we have many different drugs compared to when I was in medical school. And so it's really, I actually tell my patients it's a great time to have psoriatic arthritis because I only had 1 drug when I graduated from med school, and now, you know, I have, you know, over 10 that we could possibly use. So next slide, and I'm having a little trouble getting to the next slide. I don't know, Bev. Oh, kind of jumped there. So let's go on to the challenges of diagnosing, since this is sort of the bulk of our talk. Unfortunately, because it doesn't occur right at the same time as the psoriasis, sometimes there is a delay in diagnosis because people don't necessarily put together that, wow, I have skin disease and now all of a sudden I have joint disease, and maybe it's part of the same diagnosis. So sometimes it can take several years before people can make that kind of association. And then there's also many things that cause joint pain, as you know. Many of us, as we're starting to open back up the cities and towns that you live in, you might be exercising more, and sometimes you can get an overuse injury, for example. So you can also have other related, really unique features that can develop. You can sometimes it can affect your mental health. Sometimes it can affect your bones, like osteoporosis. So there's other sort of related diseases that can occur with psoriatic arthritis, and not everybody presents all at once with all of these. So these are some of the comorbidities. And then unfortunately, we do not have sort of a test, like we do for diabetes or other diseases where you can go in and just give a blood sample and the rheumatologist can say, oh yes, Mrs. X, you have it, or Mr. Y, you have psoriatic arthritis. So it's a clinical diagnosis, which means you have to get to know your rheumatologist. And some people present really obvious, and I don't really need a lot of time to think about it. Their history, their exam, their family history, their imaging and labs all point to together point to psoriatic arthritis. And then sometimes it's a lot harder, and I have to visit with my patients for several visits before I can feel confident. And it's not a diagnosis that I take lightly. Despite I see a lot of psoriatic arthritis patients, I still, every time before I really make that diagnosis, I want to be really sure. And if I'm not, I'll need to tell my patient that we got to maybe rule out some other things before we really come to the conclusion of psoriatic arthritis. So we're going to talk a little bit about the different types of psoriatic arthritis as well. It can affect both the joint-related issues as well as the non-joint-related issues. So musculoskeletal versus non-musculoskeletal. So musculoskeletal symptoms refer to the process by which the bone, the cartilage, the ligaments, the tendons is actually the reason for the pain and tenderness. The non-sort of joint symptoms refers to the overall fatigue that sometimes affects patients, stiffness in the joints that can occur, especially in the morning. So we're not talking about just stiffness, when after a long car ride, for instance. We're talking when the alarm goes off, patients don't even, can't even like pull their covers off. They have to like almost think about it because all their joints are so stiff. When they're trying to get up. They can get skin and nail lesions. It can also affect the eye by something called uveitis, and then they can get subclinical colitis as well. It can affect 1, 2, or 3 joints, or it can affect joints on both sides, both wrists, both hands, both ankles, for instance. So it can be really varied. So unfortunately, there's no specific pattern that always clues us in it. People can present very differently. We do separate them into domains. So I just talked about all the different things, the skin and the nail changes, the peripheral arthritis, meaning peripheral means more in your hands and your feet, enthesitis, which is something around the joint, which is more of where the tendon meets the bone, and dactylitis, which is sausage toes, sausage fingers that you can get because the entire tendon sheath is inflamed by psoriatic arthritis. And then there's a small subset, maybe less than a quarter, less than 25%, that can get axial involvement, meaning they get psoriasis and the presentation is really just the back symptoms or the axial skeleton gets involved. So I'm going to hone in a little bit on nail psoriasis because this is a really great clue for us. It's also been known that patients with more nail involvement tend to get more psoriatic arthritis, perhaps. So this is still an area of great research interest. And nails is often missed, right? Many times people wear nail polish. Sometimes people may not look at they said, oh, I've had this nail stuff their whole lives, so they don't really think it's anything different. But there are very specific sort of nail changes that we care a lot about. So pitting is one of them, and the horizontal line. So you see here in the picture on the top, what it's trying to do is kind of show you the little pits. So that's pretty, specific to kind of psoriatic changes. You can get changes in your shape of the nail, some thickening. You can get separation, onycholysis from the nail bed. You can get discoloration, as you can see here. And then sometimes, your nails can actually crumble, which, can cause a lot of discomfort as well. But those are all signs that we look for. That's important for developing psoriatic arthritis or having very heavy nail changes. Enthesitis, this is showing a picture of the Achilles tendon. As you can see, one side is much thicker than the other side because it's inflammation. So that's where this is the easiest to see. That's why I give this example, but it can occur with any tendons throughout the body. But one of the most common one is the Achilles tendon, which is one of our biggest tendons that attaches to your heel bone. And this area, can get inflamed and cause a lot of discomfort with walking. And so we want to make sure we understand this concept because it's very unique to psoriatic arthritis. Dactylitis I talked about, where you see, sort of on the top picture there, you see that fifth finger just kind of really swollen from, from the entire finger, not just part of the finger. And so that's considered what we call a sausage digit. It can happen in your toes, it can happen in your hands, and that's very specific for psoriatic arthritis. So if you happen to have one of these, it makes the diagnosis very easy. And sometimes people don't have it all the time. It can kind of come subtly, in the feet and then start bothering you, weeks later. Sometimes it can come on really abruptly and be so painful you're like, wow, you thought you stubbed your toe, but really it's dactylitis. And then I talked to you about a little bit, where 25 to 40% of patients could get what we call axial involvement. So that means that their spine is affected and they get a lot of stiffness in the morning in their spine. It also improves with exercise, which is kind of counterintuitive, right? Because most people are like, oh my gosh, cleaning out the garage or doing a lot of exercise, makes your back worse. And that's typical for what we consider mechanical back pain. But for the psoriatic arthritis type, back pain, we're looking for morning stiffness, improvement with exercise, no improvement with rest, pain at night, kind of getting up at night because of like really sore back. That's also very helpful to know in their history. So it's important to know that, you know, just because you have psoriasis and you have some joint pain doesn't mean, oh, automatically you have psoriatic arthritis, because there's a lot of mimics. So people can get osteoarthritis or rheumatoid arthritis. So a lot of people might have heard of RA, and I think it's very common, you know, sometimes when you're trying to understand these different arthritides, you kind of say, oh yeah, I have psoriatic arthritis and rheumatoid arthritis. So probably not. It's so rare to have both. But they kind of present, you know, with joint pain. So it's kind of hard to tell, you know, for someone. But the distribution we look at, so rheumatoid arthritis is clearly more symmetrical, which is why you're seeing pictures of both the left and the right hand. Sometimes you can get rheumatoid nodules, and that's, you know, a little more specific for RA, for rheumatoid arthritis. But sometimes the symptoms are really similar, right? You get joint pain, joint stiffness, joint swelling, morning stiffness. So very similar to what I just talked about with psoriatic arthritis. However, you know, this disease does look different on X-ray. They do have maybe different laboratory parameters also that we can check. So it's important, if this runs through your mind, that you talk to your physician as well, so that it's important that they kind of know where your concerns are, or something that you read that you feel like, oh, you know, I've had these symptoms. What if I have rheumatoid arthritis instead of psoriatic arthritis? And most rheumatologists will be able to tell the difference. Osteoarthritis, this is probably the #1 arthritis that is in this country. Over, you know, 120 million people are affected by this. Your lifetime risk of osteoarthritis is very high for us, especially us living longer and using our joints longer. You know, the CDC put out a study, you know, showing that, you know, upwards of, you know, 50% of patients may eventually have some cartilage loss leading to arthritis, usually in their knees or their hips. And this, you know, sometimes can happen earlier, where people find that it's very similar to something like psoriatic arthritis. It also, osteoarthritis usually affects different joints at different times, so not like rheumatoid arthritis where it kind of all happens at once, and so therefore makes it, you know, even more of a mimic of psoriatic arthritis. So this slide is just a nice cartoon that I like to just kind of remind people. So the top one is the healthy joint. And what I want you to kind of focus on is the nice smooth surface on both sides. Like you can almost outline the joint spaces, and that's what we consider normal joint. And then as you get into the osteoarthritis, you notice that the joints kind of lose the protection and they're kind of kissing more, and, you know, that's signs of, you know, early arthritis, osteoarthritis. And then in rheumatoid arthritis, by contrast, instead of having, you know, sort of loss of cartilage, it actually has inflammation. So it's red, it's swollen, it's warm, it's hot. So this is sort of what we see in the inflammatory arthritis. The prototypical one is rheumatoid arthritis, but this is also very similar to psoriatic arthritis. In fact, it is more of an inflammatory arthritis. So it's very important to kind of notice the difference between OA and RA. So, you know, OA is definitely more what we consider the non-inflammatory, and the rheumatoid arthritis and psoriatic arthritis is considered the inflammatory arthritis. And then there's gout. So gout is also very common, usually get in the big toe. It also causes pain and joint swelling. And many patients with psoriasis can also have gout. It may not be psoriatic arthritis. So it's really important to mention that. However, gout has a very distinct clinical picture. So it's really unlikely that, you know, if you see a rheumatologist, they can really tell the difference between both. This has much more sort of acute onset, usually affects only one joint. There's intense pain. You don't even want a sheet to go over your, you know, your foot or, you know, your knee or wherever that you get affected by gout. You have elevated uric acid in your bloodstream, but, you know, definitely can mimic. So it's important to take note about gout. Fibromyalgia, also another very difficult to distinguish sometimes. Sometimes it's really obvious. Most patients have, you know, what we call secondary fibromyalgia, meaning they've been living with this chronic pain, chronic joint pain with psoriatic arthritis, and sometimes you can develop some widespread pain. So I would say psoriatic arthritis pain is much more confined to the joint and not all joints at once. In fact, I don't think I have any patients that have all their joints affected by psoriatic arthritis at the same time. So that's sort of a little bit of a key feature. So if you do feel that the pain is sort of all over, meaning both shoulders, both arms, both legs, so upper extremities, lower extremities, more widespread in, almost any area that you're sort of moving, then, fibromyalgia kind of gets higher on the list than psoriatic arthritis. You can certainly have both, which makes it, tricky, as I had mentioned. But most of the time, rheumatologists can certainly help distinguish the difference. There's also different features and treatment for fibromyalgia versus psoriatic arthritis. And sometimes, when they're so similar because they're in similar areas, sometimes I have to treat both and try to see, if the addition of a fibromyalgia treatment would help that patient. So I don't think this is all clear cut. I know a lot of people, may look down at this diagnosis. Oh, that's just, people when they don't know what's going on. But, I do think that there is what I think is called an amplified sensation for these patients that develop widespread pain. And I think it's still important, at least in my practice, for me to use this term because the treatment is very different for fibromyalgia and psoriatic arthritis versus psoriatic arthritis alone. So I think just by virtue of that, I think, people do need to, better understand that there could be, just because you have psoriatic arthritis doesn't mean it's always the main reason for all of your pain. So it may be important to, make sure you don't have other mimics or associated conditions. So what do I go through when, somebody presents with psoriasis or maybe psoriasis and psoriatic arthritis? What do I do when, what should I expect when I'm going to see a physician about this? So I think it's really important to understand your history. So, just talking to the patient, just trying to get a sense of, if psoriasis runs in the family, are you just the first one who's ever gotten a diagnosis of psoriasis? Maybe how long these symptoms occur, whether have these kind of very unique symptoms that I talked about, which is dactylitis and enthesitis, nail changes, and then also your lifestyle habits. I gotta tell you, lifestyle habits are super important in terms of, how you may react to a chronic illness. We also do an exam after we take a history. So I really want to see what the joints look like. And now that we're doing a lot of virtual visits, I'm getting better at, really trying to do as much as I can virtually, to not just look at the joints, but to have them do some functional measures so that I can try to get an idea of, how much swelling, might exist. And then blood tests are really important. So we look for markers of inflammation, and things like ruling out things like rheumatoid arthritis as well. And then one of the most important things is to get some imaging. So sometimes we do it at baseline, sometimes we do it when you're symptomatic, but taken all together, these are really helpful. If you have really early disease, meaning it only happened within less than 6 weeks, I probably wouldn't, do any imaging because sometimes I don't want to expose my patients to radiation. So even though we do it the majority of the time, there may be select cases where I may not jump to imaging. Also, we see a lot of young women that are family planning. So I'm a bit more conservative and I sometimes, think about, well, I'm only going to get it if I'm going to change my management. So if I already have a course in mind, I may just treat the patient and maybe do imaging down the road just to avoid a lot of radiation exposure. Just depends on the case. There are some screening tools that are out there. There's many that's out there. This particular one is a couple of questions that the NPF has put on their website that many of you can get access to just by logging on to the website. And they ask a couple questions. And if you do have any of these questions that are affirmative or positive, then you should most likely want to talk to your primary care or get referral to see a rheumatologist. And so if you have any of these sort of unique features, I would, encourage you to go see a rheumatologist rather than, maybe sit at home and, kind of Google psoriatic arthritis and just assume that you have it. I just think, this is probably one of the hardest things we teach our trainees coming in, trying to understand low back pain and distinguishing, trying to, understand, these swollen joints and the pattern. So I don't think it's always that clear cut. So I do think a visit with a rheumatologist is very helpful. We also believe that it's not just your dermatologist or just your rheumatologist that provides necessarily the best care. So at the Cleveland Clinic, we're a big believer in sort of team science, team care. And what I mean by that is that although my job is to diagnose the psoriatic arthritis, and I don't really expect other doctors or allied health professionals to really be the one to diagnose, I do think the rheumatologist plays a huge role in the diagnosis. But in terms of managing a patient, I do think it's really important that you find a team that doesn't mind communicating, right? So that the dermatologist and the rheumatologist aren't afraid to pick up the phone if there's something that may seem different. I don't think the patient has to be necessarily the person that, tells the dietitian and the dermatologist and the psychiatrist and the therapist and the physical therapist what each other said. I do think that, having these specialties in one system with the same EMR, for example, if you have a very difficult case, may make it a lot easier for your doctors to compare notes and to, basically translate what each other's specialties might want to do for your particular case. And then sometimes there's additional comorbidities where you might need to see a heart doctor because, sometimes patients with psoriatic arthritis can have a little bit more heart disease than those without. And so if you have a lot of risk factors like, your lipids and your high blood pressure, then maybe you would work with a cardiologist as well. So I know I wasn't really, I wasn't really tasked with treatment of psoriatic arthritis, but sometimes I feel like it's really difficult to have a talk like this and not, at all talk about treatment. So I thought maybe I'll end with a couple slides on treatment just so that you can be familiar with some of the ways that we measure things and just be prepared. So one of the newest concepts in treatment that I find really interesting in psoriatic arthritis is something called tight control versus usual care. So the question is, if you come to see me, Elaine, for psoriatic arthritis, and you come religiously every 12 weeks, and that I do something very specific every 12 weeks, versus you might be coming, every 6 months or so. Excuse me. What is there a difference between what we call tight control and treating to target, meaning I actually have a target every 12 weeks versus not? And what we see here is that the tighter the control, so the more you're on, medicines as well as lifestyle habits and changing, things like your blood pressure or your weight if you're overweight. So if you have tight control, it does look like you do better than someone who's just doing standard of care, which means you go in, but you don't necessarily change things every time you see each other. You just kind of talk about the disease, So this concept is interesting. It's called treat to target, and it's something that has really changed the way that we probably think about psoriatic arthritis. I think, in past, when I first graduated from med school, we used to think of it as, oh, it's such a slow growing disease. You don't have to worry too much. Not every patient will go on to erosive or functional decline. So you can kind of, wait a little bit. There wasn't sort of an urgency. So now we know that as little as 2 years, you can actually develop some joint damage. So we do find that, sticking to a tight control may be important. Then we have all the drugs, and although I wish I had time maybe in the next webinar to talk about treatment because it's so exciting. There's so many new treatments now for psoriatic arthritis, but I can definitely give an overview sort of the different drugs. Some are pills, some are needles, some are infusions, and it's so scary when you first hear about it. But it's just, it doesn't mean one's better than the other all the time. It's just that the way that it's made and it gets delivered to your body, sometimes we can't take it through our mouths because our GI system will unfortunately tend to break down the medicine in a way before it even gets to your body, right? So certain things have to be infused or injected. The first line is actually NSAID. So it doesn't mean that every time you see a rheumatologist, we're going to put you on one of these drugs that you might see a commercial on. It all depends on diagnosing you, determining whether you're mild, moderate, or severe disease. And once we sort of able to, kind of bucket you into mild psoriatic arthritis, or maybe moderate, or maybe severe, fast progressing. We will then have a treatment regimen. And then it depends on which joints are affected, what other comorbidities you might have. So a lot of things are sort of going through our minds, when we're offering treatment. And sometimes it's difficult, to go over every single thing, but it's still always important, I think, for my patients to speak up and ask questions, and just really tell me what some of their anxieties or challenges are. Any questions or any things they might have read on the internet that they heard of the medication. So nowadays there's just so much that's out there, and I think with the pandemic we're all really well versed at probably surfing the internet more than we have before. So those are all challenges that we face, but I think the most important thing is to find a physician that you can work with, so that these questions can be answered over time, because it's probably too difficult to expect one doctor's visit to answer, all the questions that are there. This is a fancy diagram done by GRAPPA, an organization that does a lot of research in psoriatic arthritis. And what the important thing is not for you to memorize this graph, but to know that our treatments now are very focused on domain-driven treatment. So what does that mean? So the domain-given treatments mean that whatever domain affects you the most, so each of these columns are a domain. Is it the back pain, the axial disease? Is it enthesitis that's bothering you more, dactylitis, skin, nails, or peripheral arthritis? Depending on which domain is affected, then the treatment regimen will follow that domain. But we also know that my patients might come in with enthesitis one day, and then they might come in with peripheral arthritis another day. So we're okay to like jump domains as well. And sometimes people come in with 2 or 3 domains that are affected all at once, and we're also very comfortable doing that. But I think this domain strategy is sort of important to hear, because it does change the way that we have been practicing in terms of treating psoriatic arthritis. So I just wanted to end with a little summary that early diagnosis is helpful. So I talked a little bit about that, and that's because we now have effective treatment that can really slow down the progression of the disease. So we're really encouraging diagnosis early. We're encouraging patients to step up therapy when they need to look at domain driven, and to look at inhibiting or slowing down the progression of the joint damage, because when we do that, we know that down the road the patient will maintain their function. So the reason that we as rheumatologists get so anxious about structural damage or maybe want to change drugs is because that's the one thing we know, that if we let structural damage continue, the chance of functional decline is much higher, like not tomorrow, not next year, not in 5 years, but more in 10 years. So we're trying to make decisions in real time, and then also make decisions that might affect you 10 years from now. You want to find a rheumatologist that you could work with, who can help you make an appropriate diagnosis and find a good treatment that's for you. And the NPF has a nice patient navigation center that can help you depending on where you live and what you're looking for. I also mentioned a little bit about collaborative care and having that team approach if you can. Sometimes, depending on where you live, you might have to make up that team yourself, meaning you're seeing, maybe a cardiologist here and your primary care and a dermatologist there and your rheumatologist here, but that's okay. I think just having the knowledge that collaborative care is something that, is good for your disease process. You can always be an advocate for yourself, even if you're not going to a big city, big academic center. Bev did such a great job. I'm just so proud and unbelievable about the NPF. When I started with them years ago, on the medical board before I became in the board of directors, we really had only a handful of research funding, and now we've grown to be one of, probably one of the biggest funders for researchers in psoriasis and psoriatic arthritis. And what that means to you who's listening is that this is really a great time for you to get involved in any way that you feel comfortable with. So whether or not it's just filling out a survey at home, whether it's actually becoming a patient advocate and, you know, helping in the navigation center, there's a huge spectrum of what who's living with the disease or know somebody with the disease that can help. And the NPF really has been instrumental in allowing patients to really have a voice in many different areas. In fact, just this past several years, I was on the committee that developed the guidelines for psoriatic arthritis treatment. And we had teamed up with the NPF and the ACR. ACR is American College of Rheumatology, which is my professional organization. So we got together with the NPF and the ACR to create the treatment guidelines. And what was so interesting this year, which, you know, didn't happen the years before, is that there were 2 patient representatives that was, you know, at the table with the physicians making the treatment recommendations, because we find that the input is so important. So that's testimony to that, because I have never had that before. So it's so interesting that there are patients living with psoriasis and psoriatic arthritis that are, you know, at the table doing the treatment guidelines with us. So it was very exciting, very helpful, very insightful to have that input. So hopefully some of this will resonate with you, and some of you will be able to join some of this NPF efforts, or just participating like you are today is also very helpful, because we want you to be informed and informed in a way that is more peer reviewed as well. So that is, I believe, my last slide, but I think I lost a little control here. So I'm not sure if Bev might help us end a little, or we can go right into questions and answers. Hopefully you guys have been writing down some questions and having some dialogue, which I think is always the most fun part of these sessions. I always learn a lot too.
Well, great. Thank you, Dr. Husni, for your presentation. We do have some questions. Some were submitted in advance, and we have some that are submitted tonight. So I'll start with a question that's actually showing up in both areas. The question is, does everyone with psoriasis eventually get psoriatic arthritis?
Yeah, great question. I will tell you that definitely people with psoriasis will get joint pain in their lifetime. Sometimes it is psoriatic arthritis, and sometimes it's something else. But right now, the current literature says about 30%. So like about 3 to 4 people for every 10 people that have psoriasis will develop psoriatic arthritis.
Okay, and you mentioned that you can have psoriatic arthritis along with other forms of arthritis. So someone is asking about rheumatoid arthritis. Is it possible to have both? And I think you did mention something about that. But what about osteoarthritis?
Sure, great questions, because there's so many different types of arthritis. And so, you know, it gets a little overwhelming, because sometimes when you look on the internet, or you're, you know, in the doctor's office and you see all these like charts and stuff, you're like, oh, I think I have that. Oh, I think my knee feels that way. So they all present with joint pain, and many of it presents with stiffness and swelling as well. So how do you tell the difference? So the difference is really in the pattern, meaning like which joints are affected, and also the imaging that we do. So osteoarthritis, for example, is really distinct from psoriatic arthritis, and rheumatoid arthritis also looks very differently. So can you have all 3? Possibly. Do I see that? Not really. I haven't really seen anyone with osteoarthritis, rheumatoid arthritis, and psoriatic arthritis, right? So the chances are very low that you're going to have all 3. You know, I would say it's normally one or the other. Osteoarthritis, though, because it's so common, and usually in patients that are greater than age 55, they can likely have both, but it's really unusual for, let's say, a 25-year-old to have psoriatic arthritis and osteoarthritis. So the age helps, your job helps. You know, are you in a job that requires a lot of repetitive motion, where you may have some overuse injury, versus somebody who's in a desk job, right? Or also lifestyle interventions and behaviors, right? If you are a big time smoker, we know that you, you know, can have worsening psoriasis. if you are, you know, many standard deviations overweight, that can have excess weight on your joints. So all of these factors can predispose you to other types of arthritis. But it's really unusual to have two different forms of inflammatory arthritis. So that was sort of on the right side of one of my slides. So that would be a little more rare. But, you know, every once in a while we do see some mix of arthritides, but most of the time it's one type.
Okay, thank you. And going back to symptoms, someone's asking, does enthesitis ever go away?
Oh, yes, yes. So enthesitis is actually one of the harder things that we can diagnose and treat. So it's not as obvious as joint swelling sometimes. So sometimes, you know, if the exam isn't exactly, you know, like it's not as big as that Achilles tendon I show, it's like a less amount of swelling. It's obviously harder for us to pick that up on exam, and we may have to do an ultrasound or something to kind of confirm what we might see. But most of the time when we do diagnose enthesitis, many of the treatments that are available, the anti-TNF family, the IL-17 family, the IL-12/23 family, does help get rid of the enthesitis. Sometimes we even have to inject with steroids, although we don't really like to because sometimes it can weaken the tendon, but in really severe cases, sometimes we can do that. But yes, our expectation is that we would try to treat through the enthesitis.
Okay, and we hear a lot about fatigue, and someone's sending in a question that indicating fatigue is the most difficult to manage symptom. Is this common, and what, if anything, can be done about it?
Great question. We are actually doing a lot of work on fatigue right now at the Cleveland Clinic. So to answer your question, you know, whenever it's an area of research interest, my, you know, my little antenna goes up and says, this must be something that is what we call a clinical sort of gap or an unmet need, right? So I think fatigue is difficult to even define. So I think that's some of the problems. There's a lot of emotions and things that kind of get lumped into fatigue, exhaustion, and, you know, some people could be fatigued because of actually insomnia and sleep problems, but not really because of fatigue. So if we take care of the sleep issues, the fatigue gets better. Some people, you know, have really crushing fatigue and may have, you know, additional other diseases that also contribute to fatigue. So it's not necessarily the psoriatic arthritis. So the psoriatic arthritis gets treated and you still have crushing fatigue. Sometimes you have to think, okay, what else is going on in this patient, rather than say, okay, we got to switch meds because, you know, the psoriatic arthritis is not doing well. Most of the times when the fatigue has to do with the psoriatic arthritis, I mean, most of the time, so I don't want to make, you know, end all be all statements, the psoriatic arthritis is active. When the psoriatic arthritis is less active or well controlled, or what we call low disease activity, and the fatigue is up here, but the disease activity is down there, then I would say that mismatch, I would feel that I need to look at other things to cause the fatigue. But if the disease is very high and the fatigue's high, and when the disease goes down and the fatigue goes down, then I would say it's more correlated with the disease. So not with everybody, but these are just some of the things that we think of. And we also, you know, always are constantly thinking like we don't want to miss something else that can cause fatigue, you know. So in terms of what to do about it, I think that what's frustrating is that there may not be sort of a drug option for fatigue, but really more lifestyle changes that can help with fatigue. And I think lifestyle changes are always much harder to incorporate than to give somebody a prescription for a pill or prescription for an injectable medication. So I think part of that is, you know, when I say, wow, you know, your fatigue may be due to, you know, some of these changes that we need to do, you know, manage your stress at home, you know, hearing what's going on, managing your sleep, changing your diet so you're not, you know, you're eating more fresh fruits and vegetables and antioxidants and, you know, heart healthy and nutrition dense foods instead of empty calories, you know. So all of those can contribute to fatigue, but I think it's also really hard to make those changes. So yes, I do think, you know, the short answer is that there are treatments for fatigue, but I don't think it's going to be as straightforward as we all hope.
thank you. And kind of a similar question. This individual was diagnosed with psoriasis that's moderate and severe. Is there anything they can do to avoid the potential for psoriatic arthritis?
Oh my gosh, what a great question. So we are trying to see how we can do that. Right now, I don't think we are there yet. It doesn't, we haven't had enough studies to say, okay, if you have this amount of psoriasis, if you do this, you'll never get psoriatic arthritis. I think we have to understand better this transition, and many very smart people are trying to figure that out. And I think the key is for people like you in the audience who live with this disease to let us know as much as possible in surveys and, talking to the NPF about, what kind of things, were you feeling when you transitioned? I think early diagnosis, I mean, there's so much going into that answer, but the short answer is we probably don't have anything specific that we can do that will definitely, not put somebody into psoriatic arthritis. I must say that as a physician and just taking care of these patients over 20 years, I feel that if you control your psoriasis, I do think it improves your overall health, which therefore I believe will, lower your risk for psoriatic arthritis. Whether or not I can prove that to you right now, probably not. But I do have a lot of anxiety for uncontrolled disease. So I do want to control disease because I think it helps with the hardest, associated conditions like heart disease, bone disease, eye disease, things that are common with psoriatic arthritis. I do think that keeping yourself in low disease activity only helps. So that would be my recommendation. Whether there's specifically something to do or eat or take to prevent psoriatic arthritis, I don't think we're there yet.
Okay, and another question about symptoms. Does psoriatic arthritis affect more than the joints? Early on, you mentioned the eyes and the bowel system. Can you talk a little bit more about what other effects it could have?
Yes. So I think this is what makes this disease so interesting, but at the same time, unclear. Like, why would psoriatic arthritis affect the eye? It just seems like such a strange thing to have, something called uveitis, which is the most common thing that affects patients with psoriatic arthritis. Or why should you get more, colitis-like symptoms? So we don't know the answer to that specifically, but we do know which organ systems are much more common. So uveitis definitely is much more common in patients with psoriatic arthritis than patients with gout, for example. We know that mental health issues are much more common in psoriasis and psoriatic arthritis compared to other arthritides. So given sort of the history of it and what we've known with the large epidemiologic studies in psoriatic arthritis, we do know sort of the top things that can be affected, such as the cardiovascular system. We know that you can get more osteoporosis, so you have to have good, bone health, know your vitamin D. If you don't take in a lot of calcium, then to, add calcium to your diet, get a bone density when you can, talk to your doctor about bone health. The cardiovascular, know about your risk factors like high blood pressure, smoking, all of those things that is not good for you, is not something that you want to quit, down the road or next year. It's today, it's today. If you're diagnosed with psoriasis or psoriatic arthritis, it's important to get rid of those risk factors, get your high blood pressure controlled, get your weight under better control. I think also helps with these comorbidities. But yes, unfortunately, there is a list of comorbidities that we are specifically worried about if you're diagnosed with psoriasis and psoriatic arthritis. So that's one reason that, perhaps, people get a little lazy with their blood draws or visiting their doctor when things are going well. I think it's important to know that sometimes over time, the disease can affect different organs. And so it is important to stay in touch with your rheumatologist or your dermatologist to just review some of those every once in a while, even when you're very, very stable.
Okay, good idea. And just one other question. Does psoriatic arthritis present differently in children and teens versus adults?
Yeah, so I'm not a pediatric rheumatologist, but I do see some people that are sort of in that transition stage, so sort of late teens, early adulthoods. But our pediatric rheumatologists are very well versed at some of the differences. They have predominantly, the children, I mean, can have with psoriatic arthritis a more enthesitis dominant picture. So they get much more of the enthesial inflammation than adults do. And so that is something that I think is important to note. So yes, there are differences between adults and children, but there are also a lot of similarities, right? So, you know, getting plaque psoriasis is the most common that causes the psoriatic arthritis. So there are things that are common, but I would say one of the things that really distinguishes is more of an enthesitis predominant picture in patients that are younger.
Okay, great. Thank you. All right. We have many questions and we certainly can't get to them all tonight. So I would encourage you, if you have other questions, please contact our Patient Navigation Center and I will put that information up shortly. So again, thank you, Dr. Husni. You had a great presentation. I think it was a nice overview of how to diagnose psoriatic arthritis and very informative. And thanks for taking all the questions. As I said, we have many more, but we can only do so many for tonight. So thank you very much for all of
All
your help.
right. Thank you, Bev, for having such a great intro, and I wanted to thank people that stayed on this webinar. I really appreciate those trying to learn from the NPF and learn more about psoriasis and psoriatic arthritis. So thank you. Have a good
Great.
evening.
You too. Thank you. All right, and we still have a few days left in May, which is Psoriatic Arthritis Action Month. So during May, the NPF is encouraging those who have the disease to learn more. If you're at risk, you can take a short questionnaire to assess your risk. We encourage folks to take small steps to move more, and be sure to request our free e-kit with information about psoriasis, psoriatic arthritis, and assistive devices to help you stay mobile. You can learn more about treatment options as well and learn how to set small goals. So the URL where you can obtain that information is listed on the screen. Also, encourage you to continue to learn more about the disease. Podcasts are available through Apple Podcasts, Google Play, Ghana, Spotify, iHeartRadio, or feed service of your choice. You can access podcasts listed on the screen. If you'd like to listen more to episode like 71, talks about nuances of fatigue and psoriatic arthritis by dermatologist and rheumatologist Dr. Sakeshi Khatri. You can learn more about domains of psoriatic arthritis with rheumatologist Dr. Evan Siegel, or choose a recent episode, number 126, discussing how to choose joint-friendly exercises for psoriatic disease with physical therapist and orthopedic clinical specialist Pam Bowling. You can also continue to hear more about the diagnosis of psoriatic arthritis from Dr. Husni with episode number 73. As I mentioned earlier, contact the Patient Navigation Center, the world's first personalized support center for people impacted by psoriatic disease. If you still have questions, would like additional information about treatment options, need help finding a rheumatologist or other physician, or are having issues with accessing treatments, you can contact our Patient Navigation Center by phone, email, or live chat as indicated on the screen. You can also contact the Navigation Center to ask about connecting with others through the one-to-one program, or again, request a free e-kit about psoriasis, psoriatic arthritis, and assistive devices. Reach out at education@psoriasis.org or call 1-800-723-9166, option 1. Once you leave today's webinar, you'll receive a survey to provide feedback about the presentation. Tell us what you think. We appreciate and value your comments. Thank you again to our sponsors, AbbVie, Amgen, Bristol-Myers Squibb, Janssen Pharmaceutical Companies of Johnson & Johnson, and Novartis for their support of today's webinar. And finally, you can access our webcast archive at psoriasis.org/watch-and-listen. This is where a recording of tonight's presentation will be posted. We'll also send you the link for those of you who registered and also attended. So this concludes our presentation for today. Thank you for attending.